This video is going to be on joint pathology. Now, your skeleton is this giant scaffold, this giant support structure, and a lot of things attached to your skeleton, like your muscles. That's what helps locomotion. And also your bone attaches to your bone. We're not just one giant bone. We're made up of multiple bones that are attached to each other. And when they attach to each other, we call those joints. So when your bone attaches to your bone, we call those joints, and it allows movement. So, bone to bone attachment is called joints. And they attach together. Let's pretend this is like one bone. And recall at the end you have a little bit of cartilage left, articular cartilage. Is there other bone that's going to attach to? It attaches to each other by something called a ligament. This is just connective tissue. Alright, that's what connects bone to bone. You can also have a lining called synovial membrane that secretes lubrication, usually in the form of hyaluronic acid. That allows our joints to move freely. We're able to move our joints freely. It's not like bone grating on each other. That'd be terrible. So that's lubrication. That's kind of our basis of our joints. And joint pathology is what we're going to be talking about today. And we're going to break up joint pathology into groups. We're going to talk about something called osteoarthritis and rheumatoid arthritis. We're going to talk about something called gout and pseudogout. And then we're just going to end our talk with seronegative joint diseases. So we break them up into groups. And the reason we do that is because these two look very similar to each other. And the board wants you to be able to use those differential skills to make sure you really hone in and see which one is which. Okay, so we'll start with osteoarthritis and rheumatoid arthritis first. Osteoarthritis is read as OA, is wear and tear of your joints. So when we're all going to get old eventually, and we're just all going to have osteoarthritis. That's just wear and tear. Yeah, that's a normal process, and it can cause pain, as you can imagine. This is our joint with our little cartilage on the top. You'll eventually wear down that cartilage. You also wear down the bone beneath the cartilage. We'll call that subchondral bone, or underneath the cartilage bone. And that's all wear and tear. There's no inflammation or any sort of inflammatory response. It's just mechanical wear and tear. What are some signs? You're going to have joint pain in the morning. And it'll get worse through the day. Why does it get worse through the day? Well, aren't you moving through the day? So that's just more wear and tear. So worse through the day. And it's worse at your weight-bearing joints, and that shouldn't surprise you because that's what wears and tears. So things like your shoulders, things like your hips, even your fingers, your fingers, because you're using them so much, can wear and tear. I should probably stop doing this. It's probably increasing my risk for osteoarthritis. So, weight-bearing and your fingers. What are some physical exam signs? Well, when you have stress on your bone, you're going to try and grow more bone. However, that bone growth isn't particularly how we want it. You get these nuggets of bone called osteophytes. Osteophytes. Commonly just called bone spurs. So you see these little nuggets of bone. And you can see it in your fingers. You can see it in your knees. You can see it everywhere. Fingers is a classical one. Fingers. Bone spurs. And it affects the joints of your hand. Now we'll just recap. So let's recap the anatomy, the bones of your hand. So at the base of your hand, those are your carpal bones, your metacarpals, your phalangeals. So joints between your carpal and your metacarpal will be your metacarpal joints. Between your metacarpal and your phalangeal will be your metacarpal phalangeal joints, and then between your different phalanges will be your interphalangeal joints. So in osteoarthritis, it loves to affect the DIP, or distal interphalangeal joints, your PIP, or proximal interphalangeal joints, and your first CMC, that's basically your first thumb joint. So pictures will be in my notes. When you have these involvement, you'll see the bone spurs. You'll actually see these coming out of your fingers. So this is what your finger will look like. These little spurs, bone spurs coming out of your fingers. And the DIP is called Heberden nodes. PIP is called Bouchard's. One thing it doesn't affect is MCP, so it does not affect the MCP, or your metacarpal phalangeal joints. Your metacarpal phalangeal joints instead are affected by our next topic, rheumatoid arthritis. That's a nice segue, rheumatoid arthritis. Rheumatoid arthritis is not wear and tear. Rheumatoid arthritis is a chronic autoinflammation, so you're gonna have inflammation, autoimmune inflammation. And that just wreaks havoc on your joints. All those cells releasing cytokines just destroys your cartilage, destroys your joints, forms granulation tissue called pannus. That just makes things worse. You're gonna have systemic signs because it's a systemic autoimmune disease. Fever, weight loss, all those things. And so what's the etiology? Why do you have this? Well, something's wrong with your immune system. In particular, it is associated with HLA-DR4. Now, HLA-DR4, saying that doesn't mean anything to anybody. What does HLA-DR4 stand for? What does it mean? Why is it significant? How does it cause autoimmune disease? HLA is human leukocytic antigen gene. In particular, it makes MH1s. So recall, those are your major histocompatibility complexes, proteins that modulate immune function. Okay, so you have something wrong with that, then you can have autoimmune disease. Now, HLA-DR codes for what type of MHC class? That'd be your MHC2. Okay, so something goes wrong, codes for abnormal MHC2, and you can have autoimmune destruction. That's why it's associated with HLA-DR4. Don't just memorize it, understand why it causes what it causes. So if you can imagine, you have that autoimmune inflammation. What are some lab findings? You're actually going to see the autoimmune antibodies in your blood. One of them is called rheumatoid factor, fitting name. Rheumatoid factor is actually an antibody against your own antibody. How wicked is that? So it's antibody against IgG. That's rheumatoid factor. You have something else called anti-citrullinated peptide. This is just an antibody against proteins that have a citrulline group on it. And this is actually more specific to RA, rheumatoid arthritis, more specific. I've seen a lot of questions about this. They'll talk about something that's RA and ask you what's the most specific lab test you want to do. And when you read the answer choices, you see rheumatoid factor and you kind of want to jump to it. Don't jump to it. That's not the more specific one. Anti-citrullinated peptide is more specific. You know that. I'm going to put a star right here. Hopefully you remember that. Those are your lab findings. What are your physical findings? What is the things you'll pick up right away? I'm going to erase osteoarthritis findings because I want you to refresh me. What's osteoarthritis findings? That'd be your DIP, PIP, CMC joints. And it spares your MCP. Okay? Rheumatoid arthritis is going to be kind of like the opposite of that. So RA will affect your MCP. It'll affect your PIP, so your proximal interphalangeal joints. But it won't affect your DIP or your CMC joints. Okay, so it's kind of the opposite of that. Easy giveaway. If that's not easy enough, then you can have very, very characteristic rheumatoid arthritis findings. You'll have ulnar deviation. This is when your fingers deviate to your ulnar. So they go like this. They can just show you a picture of someone's hand like this or an x-ray of that. Don't have to say anything in the history. Just show you that picture, you know it's rheumatoid arthritis. Again, picture's very specific, it'll be in my notes, so know that well. Ulnar deviation. You can also have other things like swan neck deformity where your finger's like this. So all these small deformities, but this one is the biggest, most specific one. And it's usually symmetrical, and that's just the granulation tissue and the scar tissue causing your fingers to get deformed. Now let's start for this. Just hoping you remember that. Treatment. NSAIDs. Just for the pain. If they have an acute flare-up, you want to give them glucocorticoids. So right, acute, important you know that. I've seen questions where someone will have a chronic RA that's not really affecting them, but then they'll have an acute flare-up and they'll ask you what you want to do. Glucocorticoids, again, that just suppresses your immune system. This is an autoimmune response, right? So glucocorticoids suppresses that. relieves the symptoms of RA. Long term, or if they're not tolerating this or it's getting worse long term, you're going to look for immune modulators. These are things like methotrexate, things like TNF-alpha inhibitors. What the heck is TNF-alpha inhibitors? TNF-alpha is an important cytokine. You know it probably because you talk about granulomas and formations of granulomas, so you use TNF-alpha. By inhibiting that, you inhibit your immune function, and you kind of relieve the symptoms of RA. You can do this through several ways. You can give etanercept. I usually just call it Intercept because that's what it does. It's a protein decoy that binds to TNF-alpha, kind of takes it out of the running. Yeah. So Intercept sounds like Intercept. Easy way to remember the mechanism of that. You can also have a monoclonal antibody that just binds TNF-alpha outright. We call that infliximab. MAB being a monoclonal antibody just binds TNF-alpha, takes it out of running. So all those block TNF-alpha and alleviate the symptoms. Can you guess what the side effect is? It'll be immune suppression. So something you should know, it causes immune suppression, causes you to get more infections, also causes latent infections to reactivate. An important one is latent TB. You'll get a question about someone who's taking immune modulators for RA. Might be Intercept, and then might ask, what's the mechanism? You'll know the mechanism. Or they might ask, what do you do before you give the drug? You do the PPD test, the test for latent TB, to make sure you don't reactivate that TB. That'd be terrible. Try and treat RA and you give them tuberculosis. So give them PPD testing before you give them any of these TNF-alpha inhibitors, okay? That is OA, RA. Let's talk about gout. Gout and pseudogout. So gout is when you have increased uric acid, and that uric acid precipitates as crystals. Fancy name for that? Monosodium urate crystals. And your body sees that crystal, says that's not normal. And so inflammatory cells go in and release a ton of cytokines, and that's what causes the pain and all the inflammation in gout. Usually the pain and inflammation is in your first big toe. You don't see what I'm pointing to, but I'm pointing to my first big toe. So first big toe. And chronic inflammation will cause these chronic deposits called tophi. You'll see these giant lumps on their toe just from chronic inflammation and chronic deposition of these crystals. It can also deposit in your renal tubules. Uric acid is already bad enough for your renal tubules, but it can deposit in there. It can destroy your kidneys, so I'll just write kidney damage. And if you aspirate these crystals, they're needle shaped. And they're negative birefringent. This is a fancy way of saying when you shine light on it, it looks yellow. Yellow. So it's yellow needle-shaped crystal. Again, picture will be in my notes. Make sure you know well. Common thing. They, again, very specific. They could just show you a yellow crystal that's needle-shaped and say nothing more. You have to know it's gout. What causes increased uric acid? Well, you can have under-excretion. You excrete uric acid in your kidneys. So if you're changing the way you excrete things, like with diuretics like thiazides make you pee more, yeah, but it also makes you lose salt. That's kind of this mechanism, and your body will try and increase other salt use to kind of compensate for that, and one of them being uric acid. You can have alcohol that competes against uric acid secretion. You can have overproduction or too much intake. Meat, because meat has a lot of purines that make up uric acid. One of the most common things they'll tell a patient that has gout is avoid eating meat, especially red meat, and avoid drinking alcohol. Yeah, if they eat a lot of meat and they drink a lot of alcohol, they can precipitate an attack. So you want to avoid those stressors. You can also have increased uric acid from high cell turnover if you have cancer, unfortunately, because our cells will die if you give chemo and release all that uric acid. And then things like Lesh-Nihon. What the heck is leishmania? We talked about it in our biochem, hopefully you remember. Let's just talk about our uric acid pathway. So uric acid comes from DNA, comes from purines mainly. Purines will get broken down to hypoxanthine. Eventually xanthine, uric acid, and that goes into our kidneys out as urine. Okay, so purines are a valuable commodity. DNA is a valuable commodity. We want to make more DNA, so we use purines to do that. So we want to recycle as much purines as we can. The thing that recycles it is going to be this enzyme called HGPRT. If you have a deficiency in the enzyme, you have leishmania. When you have a deficiency in the enzyme, you can't recycle it. So everything gets shuttled down into uric acid. You're gonna have so much uric acid, like I said, it'll precipitate out as crystals. It usually affects children because of the enzyme deficiency, so they have the deficiency right off the bat. So you're gonna open up the diaper, you're gonna see these orange crystals. Uric acid is gonna cause mental retardation, they're gonna have gout. So all these signs because they have increased uric acid. They can't recycle it. Everything just gets shuttled down into uric acid. How do you turn purine all the way down to uric acid? Let's see what enzymes do what. So you have something called xanthine oxidase. You can imagine these work on anything that starts with or has xanthine in the name. That's exactly what it does. So it works here, works here. These are the enzymes that turn hypoxanthine and xanthine into uric acid. Then uric acid, you pee out. All right, that was a little aside for gout. Let's go back to our talk on gout and pseudogout. Well, we finished gout mostly. Let's talk about pseudogout. Now, pseudogout is also called calcium pyrophosphate deposition disease. And I like this name a lot more than pseudogout because it tells you exactly what it is. It's a deposit of crystals in your joints that causes pain and causes inflammatory cells to migrate. Sounds a lot like gout, doesn't it? What we call pseudogout. But when you call it calcium pyrophosphate deposition disease, then you know exactly why it isn't gout. Because those crystals are calcium pyrophosphate. So crystals are different. And because it's made out of calcium, you can actually see calcium deposits on X-ray. So it's a calcinosis, and it likes your knee. That's another important part. What does gout like? What anatomical position or part? That'd be your big first toe. This affects your knee. And then that calcium crystals, they're chemically and structurally different, so they're gonna look different when you aspirate them. They're gonna be rhomboid shaped. That's kind of cool. They're going to be positive birefringent. Again, another fancy word for saying blue. You're going to see these blue rhomboids. Very specific. Show you a picture. Don't have to say anything more. You know it's pseudogout. And then they'll ask you any myriad of questions. Where does it like to deposit? Or what do you see on X-ray? Calcinosis, etc. That is gout and pseudogout. Now, how do you treat both of them? Well, what do they share in common? What's the common denominator? They're crystals that deposit that cause inflammatory cells to come in. That's the common denominator, and then everything else is different. But that's the common denominator. So we're going to work on that if we want to work on drugs that treat both. So we can give things like NSAIDs that reduces inflammation. We can give drugs like glucocorticoids that again reduces inflammation. We can give drugs called colchicine. Colchicine, what the heck is colchicine? Colchicine blocks tubulin, which inhibits microtubules. Microtubules do a ton of things. They're also used for division of cells, so you can stop inflammatory cell division. Microtubules are also used for movement. So it inhibits neutrophils from moving to the site. Inhibits neutrophil chemotaxis. And if they can't move to the site and migrate to those crystals, it can't cause inflammation. All right, that's a great drug that works on both gout and pseudogout, the common denominator. Side effects, you can imagine some side effects. You're gonna have immunosuppression. Well, that's kind of what you're trying to do. You can also have GIT upset. So if someone comes in, give them colchicine, what's some side effects you're looking for? Immunosuppression, GIT upset. Those are your common denominator drugs, drugs that work on both gout and pseudogout. However, if you want drugs that just work on gout, we have some of those. We call those our gout pathway. our uric acid pathway. Doesn't have anything to do with pseudogout because pseudogout is calcium, but this is our uric acid gout pathway. Now, what are some drugs that can work on this pathway? Well, we can have allopurinol, allopurinol blocks xanthine oxidase. That's a pretty big enzyme to block. That does like the grunt of the work. By blocking this, we can't go down the pathway and create uric acid. Very clever. So blocks uric acid formation. Another drug that does this is febuxostat. Same mechanism, give it if they can't tolerate allopurinol, or sometimes they'll ask a question, they'll talk about a researcher gives a mouse a drug that blocks xanthine oxidase, and you'll look down the question stem and you're looking for allopurinol and it won't be there. Then look for this. Okay, it does the exact same thing, exact same mechanism. Another drug, pegloticase. Pegloticase is an enzyme that works on uric acid. This enzyme is called uricase. Ace meaning enzyme, uric meaning uric. So it turns uric acid into allantoin. Allantoin is a more water-soluble form. It's just easier to pee out. That's how pegloticase works. Okay, so look for uricase that turns it into allantoin. And then last but not least, probenecid. Probenecid works on your kidneys and blocks its reuptake of uric acid. So blocks reuptake in your proximal convoluted tubule. So you don't reuptake any uric acid. So you excrete more, and that sounds good in principle, but if you have more uric acid in your urine, then you can cause uric acid stones. So side effects include uric acid stones. Those are your gout-specific drugs because it works on your gout-specific pathway. Now we're going to finish our talk with negative spondyloarthropathies. So I'm guessing way back when there used to be patients that came in with joint pain and they thought, oh, maybe it's rheumatoid arthritis. So they looked for rheumatoid factor. What was that again? It was anti-IgG. So they looked for rheumatoid factor and then realized it wasn't there and it wasn't rheumatoid arthritis. They weren't dealing with that. They were dealing with a whole entity altogether. And we call that whole entity seronegative spondyloarthropathies. Seronegative because they're negative for rheumatoid factor. What it does share in common, however, with rheumatoid arthritis is that it is autoimmune. Autoimmune. Whereas rheumatoid arthritis was related to HLA DR4, seronegative is HLA B27. What does HLA B code for? MHC proteins, but what class? MHC1, okay? So it codes for that, and if there's some sort of change, then it can cause autoimmune reactions. And there are four main ones. Easy to remember them as PAIR. So P stands for Cirrhotic Arthritis. A stands for Ankylosing Spondylitis. I stands for IBD. And then R stands for Reactive Arthritis. So cirrhotic arthritis is a patient with psoriasis that develops arthritis. So they're going to have all the signs of psoriasis. That's that gray, scaly plaque. And we're going to talk about skin disorders on the end of our block, MSK block. But just know it's that scaly, gray plaque. So psoriasis, plaque, and then they'll develop arthritis. So in the history, it'll be easy to pick up. The fingers are often affected. They can cause inflammation of the entire fingers and make these fat, sausage, inflamed fingers. We call that dactylitis. Dactylitis. And also the bone can wear down. So if this is the joint, this bone will wear down. and eventually look like this. They also call that pencil in a cup. Kind of looks like a pencil in a cup. So a pencil cup. That is cirrhotic arthritis. Now, ankylosing spondylitis. Ankylose means stiffening. Spondylo means vertebral. Itis means inflammation. This is inflammation of your vertebral column that causes stiffening. And it starts with your sacroiliac joints. Basically your lower back, sometimes even lower, sometimes your buttocks, so they might start with buttock pain. And then it starts to move up the spine. So right, spine moves up the spine, and when it moves up the spine, it causes inflammation. That's why it's called itis, and it causes granulation tissue, and your spine begins to fuse and becomes perfectly straight. Now, naturally, we have curvature in our spine that allows us to stand like we stand, but when it becomes straight, this is what you look like. Straight spine. So you have patients that look like this and have to walk like that because that straightened spine. You can see it on x-ray. We call that bamboo spine because it looks like a bamboo stalk. So write bamboo. I'll just write bamboo, no context, bamboo. Some signs that don't affect your joints that you must know is uveitis. Uveitis is a huge one. If a patient comes in with signs of ankylosing spondylitis, pain in sacroiliac joint, moving up, fusion of the spine, they might ask you what additional physical finding signs and what you look for. Red eye, uveitis. One of the lesser known ones is aortitis, inflammation of your aorta. You can have things like aortic regurg, so aortitis. And then chest wall inflammation. And this is important because it can cause restriction of your chest wall, make it difficult to breathe. Another question I've gotten on this will give you all the signs. The patient comes over with red eye, sacroiliac pain, fusion of the spine is seen on chest x-ray. How do you manage this patient? You're gonna need serial pulmonary lung function tests. You need to monitor their lung function test because you don't want their chest wall to fuse and basically suffocate them. So serial monitoring. That's ankylosing spondylitis. I erased it, but the next up was I, which stands for IBD. IBD is a patient that has IBD and has arthritis. So IBD is off the context of the MSK block. We're going to talk about IBD, we're going to talk about GIT. But just know this is someone that has inflammatory bowel disease and has arthritis. Inflammatory bowel disease is just a systemic autoimmune condition that primarily affects your gut. That's why we call it inflammatory bowel disease, but it can affect everywhere, which is evident by it affecting the joints. Last but not least, reactive. What is reactive? This is when you have a previous infection and your body freaks out and causes exaggerated autoimmune response. It reacts to that infection. That's what we call reactive arthritis in an autoimmune way, and that affects your joints, causes joint pain. Commonly from a UTI. That's the infection that precipitates it. So UTI. And so signs you'll see is urethritis, or inflammation of your urethra, so painful urination because it's a UTI. Arthritis, because that's the name of the game. And then uveitis. Here comes uveitis again. Something about the eye that really likes to be infected with these seronegative disorders. So how do you differentiate that from ankylosing spondylitis? Well, the history will be completely different. Ankylosing spondylitis has nothing to do with infection, so you can knock that right off the bat. These three are called a triad, and it shouldn't be too hard to memorize urethritis because it's from UTI, arthritis because that's the name of the game, and then uveitis because why not? It's the history will talk about a patient that has painful urination, dysuria, pelvic pain, develops arthritis, red eye. What do they have? Reactive arthritis. Easy to pick up. Now there's something that's similar that looks like reactive arthritis. I'll just finish my video by talking about it here. And that is called septic arthritis. Septic arthritis is just an infection of your joint. That is what it is. What's the difference between this and reactive arthritis? Reactive arthritis is autoimmune. So this is not autoimmune. This is just an infection of your joint, not autoimmune. Reactive arthritis, we said, had uveitis. This has nothing to do with your eyes, so no uveitis. This is just an infection of your joint. Now, causative agents include things like staph and strep. Those cause everything, seemingly. And gonococcal. Now, things get a little similar. Now, things get a little interesting. Because gonococcal can cause a UTI. So they might have that urethritis, painful urination, inflammation of the urethra. They might have that arthritis, but that arthritis is usually migratory. So they'll talk about it starting in the hips, move down to the knee, now it's to the foot. So, all right, migratory. And lastly, again, you lack the uveitis that you see in reactive. And that's what separates the two. Okay, that is joint pathology. Hope you enjoyed the video. Thanks.